Next up, just getting the microphone on, is Julia Schnabel, who has affiliations here at King's College London and in Munich at Technical University and at Helmholtz. And she will be talking about self-supervised motion reconstruction for precision MR-AI, or well, with the brackets around the A.
Thank you very much. It's a pleasure to be here. Thank you for the organizers for having me. I love popping by King's, of course, as I should. So I'd like to talk about self-supervised motion reconstruction, and I call it precision MR-AI a bit cheekily, because I think this is where we're heading, and I think it might also relate to all the other imaging modalities as well. So motion is diverse across the body. We've got rigid motion, just nodding off in the scanner and falling asleep, with your head kind of rotating, translating. We've got deformable motion, physiological motion, peristalsis. We've got motion between the different slices that are being acquired, between just different scans, or even within a single scan slice as well. So it's very difficult to deal with that. We mostly deal with this in plane, but of course it's a 3D problem, and that's the problem if you've got just planar size acquisitions. So I want to really look at the impact of MR motion. There's also a limitation maybe of reconstruction and deep learning, but it's just a general problem of the subjects that we are scanning. The problem is if you move in MRI, it alters the position of the MR signal acquired in K-space. So we have a disrupted spatial encoding due to these positional changes, and that induces all these second order effects. So we've got magnetic field homogeneity, spin history effect, we've got multiple coils we have to worry about. So it's not just as easy as performing some sort of registration, which is where I originally come from. So we have to deal with all this mess. So we've got these really complex motion artifacts after applying any box standard image reconstruction or the most sophisticated deep learning reconstruction. Now, here are just some examples of MRI motion artifacts. This is just the odd blurring of a T1-weighted MRI image. We've got a cooperative subject holding still and then asking them to move. And this is what happens. This is a ringing artifact here in the T2-weighted MRI, where you see these kind of undersampling, which you normally see when you violate the Nyquist theorem if you do undersampling, but this is a fully sampled image. You get rings as well there. And we've got just signal loss, right? So if you've got T2 star quantification and bold imaging, you actually see a signal drop, and that renders some of these scans unusable and diagnostically not valuable. And then you have to rescan the patient, so it really is disrupted to the workflow. Now, we can, of course, do something against it, just from a pure scanning point of view. I remember Paul Tofts at Queen Square putting a little ring around people's nose so they would notice when they would nod off. That was actually a very simple, practical engineering solution. You could physically constrain them. Patients don't really like that. You can ask them to hold their breath. I remember my first liver scan taken at St. Thomas's by Reza Razavi. I had to do a 40-second breath hold. And that's kind of like deep diving, right? So you have to be really young and fit, and I was at the time. For infants and pediatric patients, sedation, unfortunately, is quite often the problem, or at least getting them to fall asleep, swaddling them. That is slightly more kind on their physiology. But then you can also think about designing image acquisition schemes that take that into account by having navigators as well, who can kind of stop scanning and start scanning again, ECG gating and cardiac imaging and so on. Or you can go accelerated and parallel imaging, and that actually just reduces the acquisition time and the chance of motion occurring in the first place. So the faster you scan, the less they can move in that time, right? So prospectively, you can do real-time motion correction. You can adapt the field of view by trying to update the scanner gradients very quickly. Head motion, fortunately, is just rotational and translational. There is pulsatile brain motion. There's very little we can do about that. And then, or we can do it retrospectively by applying some correction after the acquisition. But in all those things, you need to somehow measure the motion, yeah? And we don't have a gold standard for that. We don't really know how and where motion and how much motion occurs. There's autofocusing, and I have to apologize to David because I actually just looked it up. This is just a textbook about motion correction MRI, but the autofocusing was his 2005 IPMI paper, I think, on autofocusing. So really legendary work. I remember your scans at the time. So basically, you can do some iterative correction based on the Fourier properties. You can actually formulate translation and rotation in the Fourier domain. We don't need to do motion measurements, but you can optimize the parameters by minimizing some cost functions. It's a bit like doing image registration in k-space, if you think about this, like a cost function. I think it was entropy based at the time. But reconstruction is then iterative, potentially quite long, and you have some stability challenges there. So we came up with something which was published last year in MRM. We worked on bold imaging for stroke, where we really have the problem of really having low resolution images for T2 star quantification. So we have these gradient echo brain images, and we added some physics-informed deep learning. So rather not just doing deep learning statistically, but also trying to inject some knowledge of the underlying MR physics. So if you look at T2 star quantification, what you do, you acquire a gradient echo MRI, and when you move or don't move, as you see here with a cooperative and then deliberately non-cooperative volunteer, everything's fine at the lower echo times, but as you increase the echo times, you see this signal drop happening, right? And then, of course, the T2 star quantification will suffer from that as well. Right, starting from that, Hannah Eichhorn, my PhD student, who's just finishing, she looked at this and introduced FIMO, a physics-informed motion correction method, where the assumption is that the motion happens individually across the scan time. And we were inspired by some earlier work I've done here at King's with Ilka Oxus and Andy King, where we said, well, if we know which k-space lines are corrupt and we can detect them somehow, we can just remove them. And then we convert our motion reconstruction problem into just a simple undersampling reconstruction problem, which is much easier, right? Because we've seen, Florian, despite the limitations, if you, take out all the corrupted stuff, the good stuff stays. And unless you go to 100-fold acceleration, you get some good images. Question is, how do we detect these motion corrupted lines? Because we don't know which ones are corrupt. Of course, you do simulations, as we did for cardiac imaging back here as well. But that's not very satisfactory because you really want to do it in a self-supervised way without having to have knowledge of this. So this is FIMO. Thankfully, Florian has fully explained unrolled reconstruction. We do it here for multi-echo images. So we exploit some of the redundancy in the data as well. And what we do here is we introduce FIMO as an additional part where we detect the k-space line. So the bottom network here just works on good data, on volunteers who didn't move. Yeah, so it's actually, we just throw away scan lines and it knows how to reconstruct it and everything's fine. The top network we train by arbitrarily removing k-space lines as well, but by injecting this physics loss. And this physics loss here is basically just looking at the mono-exponential fit for T2 star, basically your Bloch equation mostly, and throws away k-space lines on that grounds. Yeah, so if it doesn't fit, it's probably not good. So that's self-supervision. It actually puts in physics into the equation. Once we've done that, actually, we can run it through any kind of data sets for multi-echo imaging, and it will automatically drop out the lines which will not follow that fit. And then we'll just do a nice multi-echo unrolled reconstruction afterwards, and you get good data. There are a couple of things we need to be aware of. First of all, you have to understand Fourier. So you have to understand you have to keep the center of k-space because that's where your contrast sits. This is your, I always call it DC as opposed to the AC, right? So this is basically where your mean intensity sits. It's unfortunate if the motion occurs there. That's always a problem, right? We can't help that. What we can do, however, we can you look at the odd and even slices separately. So basically, we make use of the interleaved acquisition and then just have to, for a certain set of slices, we optimize and don't have to do it for every slice separately. So that actually works pretty well. What we did then here, we had again our nice volunteer, motion free. And then we asked them to move with a strong motion. And we did a timed experiment. So we basically said, now move, stop moving, now move, stop moving. So we know in principle at which time they moved and at which time the case baseline was acquired. This is as close as we can get, apart from navigators, to what might resemble ground truth. So you see on the far right, I'm sure there's a little thing, yep. You see basically what we call now the gold standard, right? These are the lines which will be corrupt, and these are the lines which we detected. This is when we don't use the center of K-space and not the even-odd extension. So this is just a precursor of our method, which we had at MICA some years back. And you see we're getting pretty close. What you also see, there's still some uncertainty. So there's still some, it's not binary what we find, but something which we can use to weight. So what we do is we weight in the reconstruction, the case baseline, according to our certainty or uncertainty, how well they have been detected, which actually helps. Rather than thresholding that into a binary map, we get better results this way. We compared it also against our local gold standard by the group of Christine Breibisch, who, in addition to the normal scan, also apply half resolution and quarter resolution scans for the motion correction. So this is as good as we currently get for the clinic. And you see actually in the zoom up set, the motion stuff here kind of disappears and we get some quite good results. We have actually done this on 19 volunteers, divided into training and testing and validation, and got really quite good results there. So we basically find an increased performance for quite challenging motion patterns. And we actually also dealt with the problem here of the varying strengths of the magnetic field inhomogeneities by removing basically the stuff that doesn't work. So it's a bit like a surgical approach to K-space. If you want it's bad, you cut it out. What also the nice, so it actually has almost the same performance or comparable performance to what's currently state of the art in terms of what we get out in terms of motion reconstruction, but we save the extra acquisitions. So we still acquire the whole sequence and then only we go into undersampling. So we don't start with undersampling. We don't know which lines will be corrupt before we start scanning, right? But we don't need the additional scan. So it still is saving in scan time of 40%, which will be nice for the clinic. There's much more validation, evaluation, and testing in the full paper. We also compared it to deep image prior and other methods as well. What's also maybe nice for the community, I mean, it's not as big as fast MRI, sorry, but it is, I think, now 22 subjects, case space, with and without motion corruption, which you can download and play around with. And if you go to the MRM paper, there's just a GitHub link in it, but that takes you then to this page as well, where you can download the data and have a go yourself. We also had different grades of motion there, little motion, middle motion, high motion. It works particularly good with high motion, but it still works quite well with little motion, which you have to distinguish between noise and actual signal there. The second part of the talk, just taking the time, perfect. I want to talk about abdominal MR motion correction. So this is where we're moving from the head, where everything's nice and rigid, to that part where everything is really, really difficult to follow. And here we wanted to really do motion resolving rather than motion correction. We wanted to actually make use of the full case space as it is acquired over time and group it better together. This is work by Veronika Spieke, but also involving Claudia Preto here from formerly at King's, now in Chile. And of course, it's the MR community. It's called PISCO. We had Grappa, we had Raki before, so you know you get the point. So if you do ideally motion resolve reconstruction for abdominal MRI, you get a nice spatial signal and a nice continuous temporal signal. Now in real life, it looks like this, right? Because you keep scanning over time, and if you would take each time point and reconstruct, you would get this, and no doctor would like to see that, right? So what you do is you have a navigator, and you go through the whole breathing, you know, as you go along, and would kind of know roughly when you're at maximum or minimum inhale, and then maybe divide it up into more bins, right? So you've got your 4 motion states, but all the signal in here is grouped together, the signal in here is grouped together, and so on. So you only get 4 scans, 4 temporal scans. Very good temporal, spatial resolution, but of course temporal resolution you've lost. You just have these 4 motion states, nothing dynamic. And there's lots of interest in doing really dynamic scans. If you inject contrast, you want to do pharmacokinetics, or you want to just look at elastic properties, for example, of the liver. You know, is there something which doesn't work very well? Is it stiffer? Or, so you could actually, you know, could use the motion parameters to do some characterization of the tissue. So we've got only this, not only have you a bad temporal resolution, there's still some residual blurring left as well. So basically because you group together within 1 motion state, some slight breathing motion together, which is also not desirable. Good, so this is when neuroimplicit representation comes in. This has been taken by Wenqi Huang from Daniel Rickards' group into cardiac case space, and we've taken it with him into abdominal case space as well. What you do here is you basically train a neural network with the coordinates in case space to interpolate the case space value. This is subject specific. We don't mix subjects anymore. So whatever we hallucinate is just within 1 single subject and not across entire fast MRI, right? So here you see it's not quite as good in terms of spatial resolution, but the temporal resolution is now really nice. Yeah, and I'm sure we can crank this up over time and get this even better. So this was the start. This was 2 years ago. We then looked at what happens if we reduce the training data, if we just stop scanning after a shorter time period and throw away some data, right? This kind of temporal undersampling, if you want. And we found actually then we have overfitting because we just, you know, fit to 1 subject, to 1 case space. So it starts failing if we reduce the training data. And also it turns out that the high frequency information is also important as you go out in case where these are polar coordinate systems. So a stack of star imaging, that we start also getting blurring effects, right? So the more we can, you know, acquire, the more it is better. But of course, there's no free lunch, right? You have only that much scanning time, and you try to be good. So we again were inspired by GRAPPA, the generalized auto-calibrating parallel acquisition scheme, which introduced this kernel here, where you actually try to have a fully sampled part, some auto-calibration signal, and you derive from that weights which you can, you know, enhance in the undersampled regions, the areas a little bit better, and then solve your normal reconstruction problem. But here we said, well, we don't have that. We don't have this kind of supervision. We have to do it again self-supervised. So we have to do some self-supervised consistency measure, some loss function, which we call PISCO, parallel imaging inspired self-consistency, where we just randomly sample local neighborhoods with kernels. We played around with lots of kernels. Actually, turns out these were pretty good, so we stuck with them. We can make them bigger. But we can also have them in radial directions and other constellations. There's lots of stuff which one can still play around with, and I invite you to do just that. And basically, we can then use that. Ideally, then these weights, which we can derive from that, will be quite similar to one another, almost the same, right? So we can use one of these weight systems in our equation. So going back to NIC, the neuroimplicit case space method, that just used a data consistency term here. We add to this another loss function, the PISCO loss function, as a weighted addition to the cost function. And again, what we don't need is any additional data, so we don't have to acquire high-resolution data. We avoid the overfitting problem this way because now we regularize quite nicely and we converge much faster. Yeah? So this was just delving a bit deeper into Nick and say, how can we regularize? And we all know regularization, as long as it's done with care, is the thing we have to do. Here are some examples. This is cardiac imaging, where you see the non-uniform FFT, the XT grasp, the deep image prior, which we extended to 512 from 128, the standard Nick, one early version of the iconic, and then 2 different versions of Pisco. This is now the latest one. We see actually going down to factor 104, we get some pretty good images. Of course, we've got here the redundancy in the temporal domain, which is always nice to exploit. You see that XT grasp is still pretty good. You know, that's basically the gold standard. Deep image prior is also very good, but we actually get some sharper delineations here than the others, and I think it's quite promising results. For abdominal imaging, we looked at gated imaging, so this is as close as we can get to good data. Again, the non-uniform FFD, XT grasp, and then the two nicks basically. And it's hard to see on the projector, but basically this is the temporal dimension. You see lots of staircasing effects. You still see that for XT grasp quite a bit. And then you see for this one, it gets better, but then we get a really nice, smooth spatial and temporal appearance there as well. So we've got high temporal resolution without losing the spatial smoothness, but also having still some sharp corners in there as well. It's just another result. It's smoother than the deep image prior resolution versions as well. And basically, this is where we're going forward. This is still 2D, yeah, but liver slices are still quite thick at the time. So this is where we have to go through plane motion and other things, the resolutions. But it's quite good first work. So Nick with Pisco is a quite robust framework for improving neural network implicit representations. We get really some good quality motion resolved abdominal imaging, also really for cardiac imaging. We also look at static imaging, at just images of the thigh, of the leg. We didn't look at knees yet. And we avoid this temporal over-smoothing of the state of the art and still achieve some really good spatial temporal reconstruction quality. It's a good compromise solution at the moment. It offers a versatile self-supervised case-based loss function, which could be useful for other applications that you might have in mind and other architectures, so it's quite flexible. You can also use your favorite data consistency term in this framework and think about moving on to other modalities like PET imaging, for example. We've already discussed this, Andrew, right? If you can read the paper for further validation and evaluation results, has just come out in media. So in conclusions, and I'm really bang on time, I'm quite proud of myself. We're in 15 minutes at ECR last week. Motion matters, right? So quite often in the reconstruction world, we don't look at motion. We don't look at scans which have to be thrown away and where patients have to be recalled and which are unusable. But we can actually do something about motion and still recover images and still make them hopefully diagnostically valuable. It's best resolved where it arises, right, in case space. I'm still, honestly, David, I'm still inspired by your early autofocus work. I think this was such ancient news for you, but I really love those early images. But the self-supervised approaches are very powerful because we go away from needing this gold standard, right? We don't know where motion and when it occurs, but we can actually try to find it out automatically and by using physics-informed models, by doing appropriate regularization. And this takes us a long way towards what I call precision MRI. We still lack good reference-free standards. We all use SSIM and PSNR and all these things, but ultimately we need to evaluate then these methods on clinically relevant downstream tasks. There's not enough making images look pretty and de-blurred and whatever. They have to be useful in the clinic, right? So you have to lead to the right diagnosis, prognosis, treatment, stratification, and patient outcome. So we're always one step too much removed from that field, and I'm certainly aware of this as well. I want to give special acknowledgements to Veronika Spieker and Hannah Eichhorn, who've done this work behind this. They actually collaborated on a really nice review paper, which came out at TMI 2 years ago, like a comprehensive review on retrospective motion correction using deep learning in MRI. So you feel free to have a look at that. And Hannah also collaborated with Elisa Marchetto and Melanie Gantz on really looking at how well do these quality metrics, which we all use in reconstruction, agree actually with the radiological evaluation if there's motion in the images. So actually doing visual reading compared to actually just calculating these things. So also left to me to thank my group, my funders, and you all for listening. Thank you very much.